Good morning and welcome to today's webinar, Community Crisis Stabilization, Models to Consider and Lessons Learned. I'm Heather Bradley, the Network Coordinator for DSRIP at the Adirondack Health Institute. I would like to take a moment to introduce your presenter today. Craig Amoth is the current President and CEO of Behavioral Health Services North in Plattsburgh. Craig holds a bachelor's degree in psychology and master's degrees in guidance and counseling and marriage and family therapy. Craig has been involved in the behavioral health field for more than 35 years. He was previously the CEO of 3 other behavioral health organizations. Craig has been through several Medicaid transitions in other states and has developed 2 separate community crisis stabilization projects, which he will discuss with us today. And I will hand the presentation over to Craig.
Great. Thank you, Heather. Well, welcome everybody. I'm happy to be with you here this morning. If you're on this webinar, you're aware that our Northern DSRIP group has agreed to take a look at behavioral health community crisis stabilization as one of our options. When it became known that I'd actually set several of these up in other states, I was asked to put together a presentation that could talk a little bit about some of the process that we went through to get these things established, what some of the decision points were, and then possibly some of the lessons learned with the hope that that might help inform our process up here in the North Country. So I'm happy to do that. Mentioned these were done in 2 other states. They were both very rural states, so they have a lot of application, I think, to the circumstances that we're dealing with up here in the North Country. The very first one that I was involved in was called the Hope House. Now, the Hope House was actually located in Cody, Wyoming. For those of you that may not be familiar with Cody, Cody is actually the western gateway into Yellowstone National Park. And Cody's the namesake of Buffalo Bill Cody, who's the, as you probably are aware, the western figure, and he established the town around the late 1800s, early 1900s. And also, Wyoming is the least populated state in the nation. There's actually more antelope in Wyoming than there are people, so to say it's rural would be an understatement. Many areas of Wyoming are actually still classified as frontier. So we had a lot of the same issues to deal with that we have up here in the Adirondack region. Cody's population was around 9,000. The entire county's population was 26,000. You contrast that with, say, up here in Plattsburgh, we're at 19,009 for the town, and Clinton County is at 81,600. So obviously the scale would need to be a little bit different here. One of the things to keep in mind that was a primary driving force for putting this together was that our state hospital was over 400 miles away. We had at the time no local psychiatrist. The state hospital had hired several psychiatrists to be traveling psychiatrists to go around to some of the more remote areas of the state. I actually had a psychiatrist for 2 days of the month to serve my entire population. So as you might imagine, a lot of the medication management was actually being done by primary care providers in the community, which actually worked out quite well. One of the other conditions that contributed to the development of this was that when clients would present as potentially endangered to self or others, they were actually either being placed in the emergency room or in the county jail. And if they were placed in the emergency room, that was problematic because they didn't feel that they were adequate to deal with the situation. And certainly jail is less than ideal to hold somebody in that state of mind. If the state did decide that they had a bed available at the state hospital, it could sometimes take anywhere from 3 to 7 days for them to arrange for that placement, and then they'd have to send up either an ambulance with several attendants, or more often than not, they'd send up a plane. So pretty costly option overall with less than ideal outcomes. So some of the circumstances, again, leading up to the Hope House, it's also important to note that this project was developed right around the time that the Supreme Court came out with the Olmstead decision. And for those of you that might not be familiar, this related to the American with Disabilities Act, and essentially the states or the National Supreme Court reaffirmed the idea that persons with a mental disability had the right to live in the community in the least restrictive environment. So the state was certainly on board. They didn't want to get embroiled into a federal lawsuit, and this helped to kind of gain their support moving forward. As you might imagine, given the circumstances, a lot of the stakeholders were pretty frustrated. The clients and the families, this was less than ideal, having their loved ones held in the jail or in the ER that really didn't want them. The ER staff were frustrated. They weren't equipped to deal with this. They really want to deal with medical emergencies. They weren't trained to deal with mental health concerns. And so they'd often call law enforcement or the sheriff to hold them. Law enforcement was frustrated because, these people really hadn't committed crimes per se, and they knew that this wasn't the most ideal place to hold them. The county legislators were also pretty frustrated because either option, they were stuck with the bill, whether they were in the ER or in the jail. And last but certainly not least, the mental health professional community knew that this was pretty poor client care, and so we needed to do something different. I think there was strong agreement. So the process that we used to move this forward was to get all the stakeholders at the table and start to define the problems and explore what options might be available to us. And clearly we had the local hospital, their administration, and ER staff were very involved in this. Law enforcement, both the city police as well as the sheriff who ran the county jail. They were at the table. The client advocacy groups were there. NAMI was very interested in coming up with alternative solutions. And as you'll see as we go through this, having the legislators involved was absolutely critical because they were a key part of the solutions as we went forward, both the city legislators, the state. And certainly last but not least, we involved the State Office of Mental Health and the division director to help us kind of think through this whole process. So through this, getting everybody at the table, we listed what our desired outcomes were for an alternative, and first and foremost, keeping clients in the community and the least restrictive setting possible was paramount. We also had some pretty big gaps in services there. We had traditional outpatient, which might see a client maybe once or twice a week at the most. And if the client really needed more intensive services, the next available option was the most restrictive, which was inpatient. So we had a big gap there to deal with. We also knew that whatever option that we were going to come up with had to be flexible because we didn't anticipate that we were going to have an economy of scale or a demand that was really going to warrant a facility that was staffed 24/7. So we had to have some flexibility in whatever developed. And clearly it needed to be cost effective. We had to have a way to not only start it, but to pay for it. And we also needed to take the available labor force into consideration because you heard about some of our challenges around the psychiatric coverage, but we also had very similar challenges around securing licensed mental health professionals. So we knew that we were going to have to think through this whole labor force issue with whatever model that we came up with. So the model that we did decide on was a two-tiered model. We decided that a community-based residence, a home, would be the ideal setting, certainly non-institutional. We figured that we could staff this during the day by mental health professionals, and then in the evening when the clients might be sleeping with paraprofessional staff, that we could have on an on-call basis. We knew we needed to bridge that gap even between this and outpatient, so we thought through the idea of a mobile crisis team. These were relatively new at the time. We knew we didn't have enough demand to put together a full ACT or assertive community treatment team. For those of you that are familiar with these, they or may not be familiar, they typically involve a psychiatrist, a nurse, a case manager, and oftentimes several other professionals, and we just didn't have to really warrant that. So at the time we felt a two-person crisis team would be sufficient, a licensed mental health professional as well as a case manager to kind of do the outreach and an engagement and provide services in the community when that was appropriate. And then certainly as part of this, this was a brand new venture for us and everybody was a little nervous about this, and so we needed to come up with a way to make sure that the clients that were being considered for a community option were being evaluated appropriately to determine the appropriate level of care and being medically cleared. And so we felt that certainly the ER would be the best place to do that if we were able to support them in the process by bringing that mobile crisis staff with the mental health expertise to bear and to team it with the local ER docs. So the steps to get from that concept to the reality were to secure the buy-in from the local hospital to jointly recruit and pay for the psychiatric coverage. We needed to secure the residents and pay for the necessary remodeling costs to bring in a code around handicap accessibility. And just I should point out here, this Hope House was actually part of our continuum of care already. It was being utilized as a drop-in center, and so it just seemed to be ideal that we could expand the resources there. And so I'll talk more about that a little bit later. And then also we needed to make sure that we found a way to not only start this project up, but to fund it on an ongoing basis. We really didn't want to start it and go through all the work with making sure that we couldn't sustain it. So we were successful in having this local faith-based organization, this church that had agreed to allow us to use the Hope House as a drop-in center to expand those services. We actually got them to not only agree to do that, but to pay for all the remodeling costs as well as for all the heating and all the other costs associated with that. They were a great partner in this process. So we really are thankful for all that they were able to do. The local hospital did agree to recruit and pay for half the costs, both a psychiatrist and advanced psychiatric nurse practitioner. So these were shared positions between the mental health center as well as the hospital, and that actually worked out quite well. And key to this is that we needed to engage the state legislators because we felt that the funding, in order to be sustainable, really needed to be earmarked into the state mental health budget. And of course, if we're going to do that, this is a state process for the budget. We're going to need to make sure that we were able to convince others that this project was worthy of the resources. And so we needed to develop an educational campaign to make sure that we could make that happen. So the results of this project, we were able to secure ongoing funding for $250,000 a year. As part of that process, we agreed to make this a regional project. So the two other surrounding counties to Park County were brought in, and we agreed to provide services for their clients as well. The residence was leased to us for $1 per year. It's a pretty good deal. We got the psychiatrist and advanced practice nurse recruited, and we were able to recruit and form the mobile crisis team. So success, but certainly there were some lessons to be learned from this process that might be applicable to our process up here. Certainly key to this was that we engaged all the relevant stakeholders early on, and without all of their support, in honesty, this really wouldn't happen. It probably took us from the time we got together to make this happen roughly, I'm going to say, a year to pull this off, and maybe even a little bit longer when we were going through the budget process here. One of the things that in hindsight I wished I would have done differently was to have engaged the neighbors earlier. We had felt that since the Hope House was already being utilized as a drop-in center, that they were already familiar with our clients and they accepted them, and this would be no big deal. But as the details of this project were being released into the community, issues got raised like, you know, are these clients going to be now showing up at 3 in the morning with an ambulance with the sirens blaring and going to be disruptive to the neighborhood? So we really had to make sure that we could go back and reassure that our neighbors that we were going to make sure that we were going to pull this project off in the least disruptive way possible. And the entire time that I was there, that we were utilizing this service, this actually never occurred. So they were reassured, and we maintained good relationships with them. What I didn't anticipate was some of the resistance that I was getting from my colleagues from around the state when there was competition for scarce resources. Wyoming's somewhat unique in the fact that a lot of their funding comes from mineral rights. Wyoming has a lot of oil and gas and clean coal, and when they're in a boom cycle, it's a lot easier to get issues passed and get funded than when they're in a bust cycle. And we're somewhere in between when this happened, and so there was certainly some competition for dollars, and so we had to do more work around bringing some of my colleagues on board and get them to support the project than I would have anticipated, and that probably delayed the process somewhat, and I would certainly make sure that we did that differently in the future. The other thing that is I think also relevant for our region up here is while on paper that regional concept made a lot of sense, in practice it really didn't work really well. And I suspect that had to do with the fact that when you're thinking a community-based service, people think community as their town and maybe a radius of 25 miles out of that. When you start getting 50, 75, 100 miles out, it starts to look less like community. And so while we certainly did take in clients from the surrounding counties, it wasn't the numbers that I would have anticipated, or certainly the need. So I think as we think through this process up here and think how we're going to maybe distribute these services across the 9 counties that I think are participating currently, we're going to want to take that into consideration. So that's the first project. The second project I was involved in was actually called the Wellstone Center for Recovery, and that was located in Eveleth, Minnesota. Eveleth, for those of you that may not be familiar with it, is actually north of Duluth, up close to the Canadian border, right up next to the Boundary Waters Canoe area. The Wellstone Center was actually named after Senator Paul Wellstone, and some of you may know that he was one of the primary sponsors of the Federal Mental Health Parity Act. Paul Wellstone was a diehard mental health advocate, and he was just a force of nature. And so unfortunately, Paul was actually killed in a plane crash just outside of Eveleth, and this picture is actually of Paul's son David, who agreed to not only lend the project the family's namesake, Wellstone, but also agreed to come and speak at our grand opening. And it's interesting that this was actually the first time that David had visited Eveleth since the death of his father. So this was actually a pretty emotional process for him, but he was very gracious, and the family lent us a portrait of Paul to hang in the lobby, and they've been just great partners through this whole thing, and it certainly led some credibility to us in Minnesota. Now, again, to look at the scope of this project, Eveleth itself is quite small, 3,700, but what's significant here is that the county population is actually quite large. It was over 200,000. This was St. Louis County. St. Louis County also includes Duluth. And St. Louis County is actually the largest county in Minnesota, but believe it or not, it's actually the second largest county in all of the U.S. So the scope here was much greater, and so we had to consider that as we were going through and looking at what options we might want to have in terms of how we wanted to scale this up. So again, some of the other circumstances leading up to the development of this project, we had psychiatric hospitals closing around the state, certainly at a much more aggressive rate than they're currently doing here in New York. We did have a local hospital psychiatric unit in Hibbing, Minnesota, but they were also scaling back. That reference up there to Bob Dylan was not so much that Bob was a resident in the psychiatric unit, but the fact that Hibbing, Minnesota is actually the place of Bob Dylan's boyhood home. So Bob Dylan grew up in that area, and if you were ever to go through Hibbing, you would see restaurants named after him and all kinds of paraphernalia. So that's Hibbing's claim to fame. It also has the world's largest hockey stick and the Hockey Hall of Fame. So anyways, the demand obviously was much higher than in Wyoming, and we had to account for that. There's often long wait periods for available psychiatric beds. Clients were actually being sent out of state. And of course, families then were having to travel long distances, similar to back in Wyoming, to get their needs met. What is different here as opposed to Wyoming is that the agency I was affiliated with already had a pretty well-developed continuum of care. And what we were really looking for was that kind of acute step down from inpatient. We already had a day treatment program. We already had a very robust assertive community treatment team. And so we were really more focused on making sure that that acute community crisis option was what we were focused on here. So again, learning from what we did back in Wyoming, the process that we went through was to, again, engage those stakeholders into the process, gain the consensus on what we wanted to accomplish. Again, the gap here was shorter, so we were really focused on that short-term acute care option. The need was anticipated to be about 6 to 8 a month here, as opposed to 3 to 4 at the most back in Wyoming. So, roughly double the census, and that was anticipated to be a fairly constant, not to kind of come and go. And so we're really assuming that it was going to be 6 to 8 on an ongoing basis, so we could think about staffing this at a much different rate. The labor issues here were less acute than they were in Wyoming. While there's a psychiatric shortage nationally, we actually had a fairly robust psychiatric component. Minnesota, I think, is much more conscious about training advanced psychiatric nurse practitioners, and so we were very fortunate to have 4 of those already on staff, and so that was less of a need. But we did have to come up with a means to fund the startup and the ongoing. So the results is that we were familiar with an empty wing of a nursing home up in Eveleth. This wing was actually being leased by the state, and it was there weren't any patients in it, but the state was actually paying for the cost. So we thought we could make better use of those resources. It was an 8-bed facility, and the cool thing about this was that there was already things in there like food service and laundry, and so we could piggyback on some of the resources that were already available. We wanted to be able to redirect some existing state dollars for the remodeling, and we also wanted to make sure that we could sustain this on an ongoing basis. And the business model that we put together was that we needed to average 6 beds to have this break even, and if we were able to sustain it at 7 or 8 census on an ongoing basis, we were actually going to make margin. So some of the lessons learned, we had the local ER, the hospital, was certainly involved with the process, but they weren't as engaged as they were in Wyoming, and so it was a bit of a harder sell when we asked them to do the medical clearing of our patients. So we had to negotiate through this, and long story short, what we ended up with is we agreed to staff the crisis center with both a mental health professional and a nurse on a 24/7 basis. So that would allow the clients to be dropped off directly to the center. We would evaluate them with the mental health professional, tag team with the nurse, and the agreement was if there were any concerns that we had that we felt they needed to be more thoroughly evaluated, the ER agreed to transport and conduct that evaluation for us. And while I was initially very hesitant to agree to that process, in practice it actually worked out quite well. I'm guessing 90 to 95% of the clients that we took in were very appropriate from the get-go, and we rarely had to actually send people back to the ER for medical clearance. So that might be helpful to us as we think through the process up here. And certainly building key relationships and maintaining them was critical. We had a wonderful relationship with a very strong state senator and state representative that really helped grease the wheels for a lot of these negotiations. That had a strong relationship with the newly appointed governor and the newly appointed commissioner for mental health, and so they were able to leverage those relationships to get this to happen and to get those resources reallocated. So at this point in time, hopefully I've covered the basics, and we'll open it up for questions.
Thank you, Craig. At this point, I would like to ask that if anybody has questions, you type them into the question part on your screen, and that way we can go through the questions. All right, and right now I'm not seeing any questions coming in. Does anyone have any questions? All right, well, if we don't have any questions at this time, you can certainly feel free to email me, hbradley@adkhi.org, and I will forward those questions to Craig, and then we can post those responses on our blog. As well, this presentation was being recorded, so it will be posted on our blog once it's made available to us. I hope you all have a wonderful day and enjoy the extra half hour. Thanks. Have a good day.